prevalence of PSA screening, especially during the time period of a lot of the studies I'm studying. Of course, like the PSA screening guidelines have changed recently. So the vast majority of prostate cancers are adenocarcinomas, which are cancers that arise from gland cells. But there's very few established like risk factors for prostate cancer, and the strongest ones are age, family history, and race. But there's a growing focus on some modifiable risk factors such as weight gain, obesity, diabetes, and smoking. And these are the ones that I'll be talking about today. But like I mentioned, it's hard to predict recurrence and diagnosis and who will have indolent cancer and who will go on to develop a more aggressive cancer. And it is a highly screened cancer, especially until recently. And recurrence is a fairly common outcome. So 20 to 30% of men will experience recurrence within 10 years after their initial diagnosis. So again, this is looking at the cancer continuum in a different way. So the vertical line, you can think of that as like diagnosis. And so then we can have pre-diagnosis exposures, and then we can have outcomes that happen after diagnosis. So the first study I'm going to talk about, we're going to look at weight gain in young adulthood. So we're looking at weight gain from age 20 to 50, which is really almost over a decade before diagnosis with prostate cancer, because people are generally diagnosed in their 60s. And the second study we're going to talk about, I'm going to be looking at diabetes and obesity at diagnosis. So here's a risk factor that was happening around time of diagnosis. And the third study I'll be talking about, we're going to be looking at a exposure that's happening after diagnosis with prostate cancer. So I chose these three studies because they kind of span the cancer continuum, and I'll refer back to this throughout the talk. So the first study we're going to talk about is weight gain in young adulthood and biochemical recurrence. So again, weight gain is the exposure we're looking at is pre-diagnosis, but the outcome we're looking at is biochemical recurrence, which is a post-diagnostic outcome. And I'll talk more about what that is in the slides that are coming up. So I just want to show this diagram to start with, and this is a paper from some of my colleagues at Washington University, and I think it highlights why it's important to look at early life exposures or exposures that occur even before diagnosis with prostate cancer, because by the time men are age 19 or 29, there can be atrophic lesions in the prostate, which are potential prostate cancer precursor lesions, and they are present in up to half of men. And then by the time men reach their 30s, some will already have evidence of high-grade prostatic interepithelial neoplasia and histological prostate cancer. So these changes in the prostate tissue are happening early in life, even before you're diagnosed with prostate cancer. So it's important to also look at risk factors in this same time period. So I want to talk a little bit about why weight gain might be associated with adverse prostate cancer outcomes. So if you have weight gain or you're obese, you're more likely to have hyperinsulinemia and lower testosterone, both of which are associated with adverse prostate cancer outcomes. And then you also were likely to have high levels of insulin-like growth factor, which is a known prostate carcinogen. As you know, smoking can promote cancer through multiple mechanisms, including hormonal changes, tobacco-related carcinogens, tumor angiogenesis, and inflammation. And another thing to think about with obesity and prostate cancer is obesity can hamper detection, because detection tests like the digital rectal exam are harder in obese men, and obese men are also more likely to have benign prostatic hyperplasia, which is an inflamed prostate, also making these exams, such as digital rectal exams, harder to diagnose cancer. So it might be diagnosed at a later stage in obese men, which is why it might be more aggressive. So this study I used for this weight gain study, I used the Washington University prospective cohort. So this is the institutional cohort from Washington University. It included men diagnosed with prostate, biopsy-confirmed prostate cancer that received treatment at the Washington University School of Medicine in St. Louis between 2003 and 2010. And all the men in this study received definitive treatment with either radical prostatectomy or radiation. So both radical prostatectomy and radiation for prostate cancer are considered treatments with a curative intent. So they're considered definitive treatments. And so the study that enrolled people from 2000, they were diagnosed with prostate cancer from 2003 to 2010, and follow-up ended in 2012. And at the enrollment, all the participants took an enrollment survey, and there was a biannual medical record review to get updated medical records. And at the end, the final analytic cohort had just over 1,000 participants, so 1,082. So the primary exposures, and again, I mentioned these are exposures happening before diagnosis with prostate cancer, was weight at age 20, weight at age 50, and then weight change from age 20 to 50. And then we also looked at effect modification by smoking status. So we looked at never smokers and ever smokers. And the reason ever smokers are combined into like a combination of former and current smokers is that there was too few current smokers to look at them alone. So we had a combined category of ever smokers. So our outcome was biochemical recurrence, which is an important clinical outcome for prostate cancer. And the definition for biochemical recurrence is somewhat different if you're treated with radical prostatectomy or radiation. And this is because after you have radical prostatectomy, your PSA, your prostate's removed, the PSA should fall to undetectable levels, where if you have radiation, the PSA drops, but it never falls to like an undetectable level. And so these are the radical prostatectomy and radiation definitions used are like nationally accepted definitions, but in the literature, you'll see a lot of variations in the definitions different people use. So for radical prostatectomy, our definition of biochemical recurrence was a PSA of 0.2 for 2 consecutive assays after treatment. So this is like you had radical prostatectomy, your PSA fell, and then you had a rise of PSA of 0.2 for 2 consecutive assays. And for radiation, it's a PSA rise of 2 nanograms per milliliter above the nadir achieved after radiation therapy. So this is just whatever your PSA felt, the lowest PSA level after the completion of radiation therapy, and plus 2 was considered recurrence. Secondary treatment was also considered a marker of recurrence. So this would be something like, say you had radical prostatectomy as your primary treatment, and then you had radiation after that. We consider that secondary treatment and a marker of recurrence. But what we wouldn't consider a recurrence is if it was like adjuvant therapy. So like if they were both given at the same time. So just a little overview on our cohort. There was 120 or 182 participants. There was 131 recurrences. The average age of diagnosis was 62. So again, when we're looking for age, weight gain from age 20 to 50, we're looking almost a decade before people are being diagnosed with prostate cancer. It's not a very racially diverse cohort. Over 90% of the cohort is white. The majority of men were treated with radical prostatectomy over radiation. And as expected, on average, men with had recurrence had higher, worse clinical measures, including higher Gleason scores, stage, and PSA at diagnosis. And as can be expected, from age 20 to 50, most men gained weight. The weight gain was a little bit higher in men with recurrence than men without recurrence. So on average, from 20 to 50, men with recurrence gained 16 kilograms, while men without recurrence gained 13 kilograms. So this is just like an overview of the characteristics of this cohort. You can see at the bottom of the x-axis, we had different, I characterized weight gain into different categories. So it goes from weight loss to the highest category of weight gain. So it's weight loss of greater than 10 kilograms. And this is again from age 20 to age 50. And then it's no change, which was less than 10 loss to less than 10 kilograms gained, and then 10 to 20 kilograms gained, and then 20 to 30 gain, and then the finest or highest categories of 30 kilogram weight gain. You can see that no recurrence is more common in the people with like no weight gain or in the lower categories of weight gain, whereas when you get into the higher categories of weight gain, so like over 20 kilograms from age 20 to 50, recurrence becomes more prevalent than among those people who had less weight gain. So you can see like if you have no weight gain, you're more likely not to have a recurrence, where if you have like greater than 30 kilograms of weight gain, your prevalence of recurrence is higher than those. And so the more men were former smokers than current smokers in our study. Former smokers were somewhat more likely to have no recurrence, where current smokers were more likely to have a recurrence. And then the no recurrence group was somewhat more likely to have a college education. I mean, none of it's super surprising, but this is an overview of just the cohort. So this is our some of our findings. And so again, we looked at weight at diagnosis, weight at 20, weight at age 50, and then weight age from age 20 to 50, controlling for weight at age 20. So these are hazard ratios for weight gain for 30 kilograms. So that's approximately 66 pounds. And so why we use 30 kilograms is that was just the weight change from the 5th to the 95th percentile of our cohort. So this is like the range of the weight gain. But we can see here that at each of these different measures, that weight gain was associated with a risk of biochemical recurrence. So weighted diagnosis has a hazard ratio of about 1.54. And then we had to weighted age 20 was also associated with risk of biochemical recurrence, weighted age 50, and then weight from age 20 to 50. So we're seeing these early life exposures and weight gain almost a decade prior to diagnosis being associated with increased risk of biochemical recurrence, which is a post-diagnostic outcome. So here is looking at the same data just a little bit differently. Instead of looking at the weight gain and as a continuous variable for 30 kilograms, here we're looking at the different categories. And again, the categories are along the x-axis and the hazard ratios are along the y-axis. And again, the categories on the x-axis are the same ones that were on the characteristic table that I showed before. But I think what's nice about this diagram is you see a very clear dose-response relationship. So the more men gained weight from age 20 to 50, the higher the hazard ratio or the greater the risk was for a biochemical recurrence. And indeed, the small number of people that lost weight were actually had a lower risk of prostate cancer recurrence. So I just see a inverse association. So I think here you see a very clear dose response. The more weight you gain, the more risk you have for risk of recurrence. And then we looked at this by smoking status because there's some limited evidence or some in a paper I did in this cohort, we saw that smoking was a risk factor for prostate cancer. Also, so here what we see is we looking at, again, hazard ratios for 30 kilograms, so as a continuous variable, but we see that the weight gain from age 20 to 50 is only significant among former smokers or ever smokers, and we don't see a significant relationship among never smokers. And probably the former smokers are stronger just because that had the, it was, the current smokers was just a very small group. So I think the data was less clean on that. So, so we see that both former smokers and ever smokers have an increased risk, and we don't see this in never smokers. So probably what this might have to do with for former smokers also is the fact that men were probably smoking at the time of the weight gain. So these former smokers were probably, gaining the weight and smoking from age 20 to 50. So there's maybe some interaction going on over there. And so what's just the main findings from this study is one of the first studies to examine weight gain decades before diagnosis. And we show that weight gain during early adult years, many years before diagnosis, is associated with a long-term risk for adverse cancer outcomes. And the associations are strongest for former or ever smokers. And that smokers with a history of weight gain may represent a high-risk group that could benefit from prostate cancer screening. And I think this is especially important because now the prostate cancer screenings are supposed to be a discussion between you and your provider. So taking into account some of these modifiable risk factors might help men make more informed decisions. All right, so now we're going to move on to another study. So this is diabetes. This is looking at diabetes, obesity, and prostate cancer aggressiveness at diagnosis and progression. And so this is different because now the exposure is at the time of diagnosis. So we're not looking prior to diagnosis. We're looking at diabetes and obesity status at the time you're diagnosed with prostate cancer. So we're going to look at two different outcomes. One's kind of a cross-sectional study where I'm looking at prostate cancer aggressiveness at diagnosis and its association with diabetes and obesity. And then another study is and the other part is more longitudinal, and it's looking at diabetes and obesity at diagnosis and biochemical recurrence, which is the same. Yes. Yeah, we adjusted for Gleason score and yeah. Sorry, I didn't mention that, but it was adjusted for those clinical factors and the results were consistent. Yeah. Okay, so like we talked about weight gain, there's also some hypotheses or mechanisms why diabetes might be associated with aggressiveness at diagnosis. So insulin is a known growth factor for prostate cancer cells. So it could be that among diabetics, there's a low insulin environment which creates a selective pressure, which only aggressive tumors can grow. And so in the few studies that have looked at diabetes and aggressiveness at diagnosis, they have reported a positive association between diabetes and prostate cancer. But these studies tend to come from clinical-based samples and are limited to a single treatment type. So here we're using a population-based sample. And the prostate cancer that does get detected among diabetics could be as aggressive, and this would be for the same reason because that we talked about for obesity. So diabetics are more likely to be obese. This could lead to difficulty with detection. They're more likely to have benign prostatic hyperplasia and a larger prostate, making the some diagnostic techniques like DREs harder to detect prostate cancer. So the cancer might be detected at a later stage. I think it's important to keep in mind that the association with diabetes and prostate cancer is temporal. So it's very interesting because there's a lot of literature that shows that having diabetes is associated with actually a reduced incidence of prostate cancer. But then when you start looking at outcomes after, like mortality or survival or recurrence, then diabetes is associated with increased risk of those outcomes. So it could be that it's the changing insulin environment that diabetics have. So it could be that newly diagnosed diabetics or those with poorly controlled diabetes could potentially have higher insulin levels, which would promote prostate cancer cell growth, and this would create an environment that promotes tumor growth and progression. So it's different at different time points throughout the prostate cancer continuum. Okay, so the cohort we're using for this study is the North Carolina-Louisiana Prostate Cancer Project. And this is a population-based cohort of patients diagnosed with incident prostate cancer between July 2004 and August 2009. So this is like during the PSA screening era. So almost everybody is getting screened with PSA for prostate cancer during this time period. So what's unique about this cohort is half of the men were African American, so they over-enrolled half African American men. So you can look at this, some of the risk factors in a high-risk population, since most of the studies, even though African American men are higher risk, are just not ethnically diverse and conducted mostly among white men. Men in both North Carolina and Louisiana were identified using state tumor registries. And then, as I mentioned, BCAP, which is what this study is referred to, enrolled Black and whites at an equal rate using a randomized recruitment method. So all the participants completed a questionnaire, and the questionnaire asked questions regarding key variables, including diabetes, screening history, and education. So these are all self-reported measures. Body measures were taken to determine BMI. So a nurse who administered the questionnaire took measurements of the participants to get the BMI, calculate height and weight, and then that was used to determine BMI. So medical records were requested from up to 3 physicians of all consenting participants. And then the stuff that we abstracted from medical records included physical exams, laboratory assays, Gleason grade, PSA, and prostate cancer treatment variables. So it's a combination of self-report and medical record data. So our primary exposure here is self-reported diabetes, and this was asked by, has a doctor or other health professional ever told you that you had diabetes or sugar diabetes? And obesity was determined based on standardized anthropometric measures taken by the nurse at the time the questionnaire was administered. And then men were categorized as normal, overweight, or obese according to accepted categories. So obese was BMI greater than 30. And our outcome is aggressiveness at diagnosis for this first part of the study. And the second part of the study, where the outcome will be progression, which is primarily biochemical recurrence. And I'll get into this more later, but that will only be among the North Carolina participants, not the whole cohort, because what happened is at the time that recruitment was occurring for the second part of the study, Hurricane Katrina happened, so they weren't able to recruit the participants from Louisiana for that part. Okay, so the outcome for this, for the cross-sectional study was the composite outcome of aggressiveness at diagnosis. And so, and it takes into account Gleason sum, TNM stage, and prostate-specific antigen. So the Gleason sum is based on the sum of the 2 most predominant Gleason grades in the tissue sample that's taken during a biopsy. And as you can see in the figure there, Gleason 1 cells are most close to normal, and grade 5 cells are poorly differentiated. So the 2 most common grades are then summed up to get the Gleason sum, and it ranges from 2 to 10. And so then the TNM stage is the traditional staging for all tumors. So it takes into account tumor characteristics, whether it has metastasized to the nodes, and then distant metastases. And then we also looked at prostate-specific antigen. So it was a composite measure taking into account these 3 different measures. And then people were characterized into high aggressive, low aggressive, and intermediate aggressive. But for the purposes of this study, we looked at high aggressive versus not highly aggressive. Okay, oh, sorry, this is a typo here. So there's 249 men in the cohort, not 1,082, and it consists of 158 white men and 991 Black men. And the average age at diagnosis was 63 years. So just over 2,000 people in our cohort. And so here are just some characteristics of the cohort by race. Like I mentioned, this is a unique cohort because half of the men are African American. As I mentioned, it's a highly screened cohort, so you can see over 80% of both white and black men are screened for PSA during this time period. Both the recruitment from North Carolina and Louisiana was equal for white and black men by design. White men were somewhat more likely to have a college education, but they were normal weight was somewhat more common in black men than white men, but black men were somewhat more likely to be obese, but you can see it's not really that different. It's very close. And then black men had a higher prevalence of diabetic, which is true with the national population as well. And then also more likely to have a highly aggressive tumor, which again, it speaks to the disparities that we see in prostate cancer. Okay. So we looked at prevalence odd ratios, and we looked at these in the cohort as a whole among white men and black men, and then we looked at obesity in all men, white men and black men. And the obesity or the diabetes models are controlling for obesity. So, but basically we found diabetes wasn't associated with prostate cancer aggressiveness in the cohort as a whole in white men or black men. What we did find, though, was obesity was associated with aggressiveness of diagnosis only among white men. So you can see that here. We had an odds ratio of 1.98. So it could be because one potential hypothesis to explain these results could be that the baseline prevalence of aggressive tumors, even in normal weight black men, is higher than that of obese white men. So maybe you have to have like a lower baseline risk to be able to see like the effect of obesity. When your baseline risk is so high, maybe you can't see the effect of these this modifiable risk factors. But so this was an interesting finding. But then we also looked at prevalence differences because the baseline risk was different. We thought maybe like the odds ratio might be masking something. So we looked at prevalence differences to account for the fact that the baseline risk in non-obese men, it was different between black and white men. And really we find that our results are very consistent. So we found no difference in the prevalence of aggressive cancer in the cohort as a whole, white men or black men, for diabetes. But then for white men, we found that obesity increased your prevalence by about 7%. So again, the prevalence differences were consistent with our odds ratios. So then for the sub-cohort of the study, which is the healthcare access and prostate cancer treatment in North Carolina, which is known as HCAP. And so HCAP is the follow-up of North Carolina PCAP participants. And again, as I mentioned, we weren't able to get follow-up data from the Louisiana participants because that Hurricane Katrina happened at the time of recruitment. So basically this is PCAP participants that were followed on average for 5 years after diagnosis. And data was collected annually from telephone interviews and medical record abstraction. And the telephone interviews use standardized questionnaires. So we were able to look at outcomes over time using this cohort, the sub-cohort of the larger study. Again, our outcome here is biochemical recurrence. It's defined similarly as it was in the previous study. So for radical prostatectomy, it was a PSA of 0.2, confirmed with a second PSA of 0.2 after achieving nadir. So this is after your PSA fell to an undetectable level. And for radiation, it was nadir plus 2. Again, nadir is just the lowest PSA achieved after completion of radiation treatment. And again, secondary treatment was also considered a marker of progression, but not adjuvant therapy. For the purposes of this study, we also defined men who were persistent. And so these are people that never achieved nadir after radical prostatectomy. So their PSA always was detectable even after surgery. So that was just kind of a way to describe this cohort. But for the outcomes that we're going to be looking at today, both persistent and recurrent, they were all combined together in a progression outcome. So here is just looking at the prevalence of progression in the cohort as a whole in white men and black men. So overall, about 20% of the men in this cohort in this time period had progression, which is consistent with national numbers. About 17% of white men had a progression, and then the progression prevalence was higher among the black men in our cohort, consistent with the disparities you see in prostate cancer. Here's just some more characteristics. So looking at it by progression status instead of by race. So the diabetes status was similar in both men with progression or not progression, so just under 20% were diabetic in both groups. Obesity was somewhat more prevalent in the men that had progression than the men that did not have progression. The non-progression men were more likely to be college educated, so that's a marker of socioeconomic status. And then, as can be expected, the clinical measures of higher aggressive tumor diagnosis and a Gleason sum greater than equal to 8 were more common in men that had a progression. So the ones that had worse clinical indicators at diagnosis were more likely to progress, which is what you would expect. Okay, so overall this cohort is, so it's less, we have less men now in this cohort because it's half of the cohort. It's 674 men, 42% of the cohort consists of Black men. Black men are more likely to be diabetic and less likely to be college educated. But what I did want to point out is something that was interesting with the obesity prevalence in white and Black men. So if you look in white men, the prevalence of obesity in men with and without progression is different. So white men without progression, there was an obesity prevalence of 30% compared to white men with progression, there was an obesity prevalence of about 45%. But when you look at Black men with and without progression, the obesity prevalence is really similar in both groups. So it's like 45 versus 46%. And again, this prevalence is similar to the prevalence in white men with progression. So we're not seeing this difference in obesity prevalences in the Black men with and without progression.
Break that down by the level?
No, because we really, to do the models, we didn't have like sample size to like break it down into even smaller categories. But yeah.
So how long was it for?
5 years. 5 years after diagnosis. So, but this is an obesity measure at the time of diagnosis, right? So it's not looking at like trajectories over time.
Had a BMI.
Worse for obesity.
Right.
Yeah.
Okay.
That's basically what this is. Yeah, exactly. Yeah, it would have been nice to look at more categories, but because we're down to like a sample size of 674, so then to run the models, it got like the cell sizes are getting too small to run the models. And sorry, this is not very clear, but these are just showing Kaplan-Meier curves of survival. So on the figure on the left, you see the diabetic is the solid line and non-diabetic is the dashed line, and you see that there's no real survival difference, and there's a lot of but when you look at the figure on the right, which is the Kaplan-Meier survival curve for obesity, so the non-obese is the solid line and the dashed line is the obese. So you see the survival is better in the non-obese men throughout the follow-up period. So then this is looking at like Kaplan-Meier curves don't take into account, like it's not a multivariate model. So then we looked at models. And again, what we see in our results is very similar to what we saw at aggressive diagnosis. So our results for progression match up with our results for aggressiveness at diagnosis. So basically we saw no association among diabetes and progression among the cohort, all men, among white men, or among Black men. However, for obesity, again, we saw that white men it was associated with progression. So there was a hazard ratio of 1.79 and an odds ratio of like 1.8 to 2.97. So it was significant in this group right here. So basically what we conclude from this study is for aggressiveness and diagnosis, diabetes is not associated with highly aggressive tumors. Obesity independent of diabetes is associated with high aggressive tumors in white men only. And then our findings for progression-free survival are very similar. Diabetes is not associated with time to progression in either white or Black men from the follow-up cohort, and obesity is associated with time to progression in white men only, both when we do and do not control for the diabetic status of men. So I think this study led to some follow-up questions, which is that obese and diabetic men are commonly on medications that may complicate any observed associations, specifically metformins and statins would be like common So metformin is the first-line anti-diabetic drug, and statins is for cholesterol. And I did look at one paper that using this cohort that looked at metformin and aggressiveness at diagnosis in PCAP, and we found that metformin was associated with improved outcomes only among white men, but this was a smaller cohort, so that led to the DoD Prostate Cancer Research Program New Investigator Grant I have to answer some of these questions. So this is the ongoing study, and I'll talk about it, and then I'll show you some very preliminary data that's not very finalized in any way. So this is the study is like chemotherapeutic potential of metformin and statins to prevent progression to lethal prostate cancer. So again, this is referring back to our cancer continuum where we first looked at pre-diagnostic exposures of weight gain, and then we looked at, in the previous study, diabetes and obesity at diagnosis. And so now we're looking at metformin and statin use after diagnosis with prostate cancer, so late in the disease course. And our outcome here is going to be mortality. So we move further down in the cancer continuum in this study. So as we talked about obesity and diabetes, there's many mechanisms. Both metformins and statins have been associated with improved prostate cancer outcomes, both a reduced risk of incidence of prostate cancer and a reduced risk of recurrence. So it's thought that metformin reduces hepatic glucose production, and because then you have this lower glucose levels, you have less prostate cancer cell growth, because we know that glucose is a growth factor for prostate cancer cells. It also is hypothesized to activate adenosine monophosphate with activated protein kinase, which inhibits cellular growth. It has an anti-inflammatory effect, and it decreases cyclin D1 levels, which can contribute to the arrest of the cell cycle. So there's multiple mechanisms by which metformin might improve prostate cancer outcomes. But one of the main one is that there's decreased circulating glucose levels, and this is associated with a decreased level of insulin-like growth factor. Statins similarly are thought to inhibit prostate cell growth through multiple mechanisms. One of the main ways is it inhibits production of milvenovate, a precursor to cholesterol and other tumorigenic molecules. It can decrease activation of oncoproteins such as RAS and Rho, and it also reduces inflammation. So there's multiple mechanisms by which these two commonly used medications might be working. So here's just an overview of the project. So if you look at pre-diagnosis, so studies such as the pre-diagnostic metformin statins associated with a reduced risk of death. And there's been a lot of studies that have also looked to see whether men diagnosed with non-metastatic prostate cancer have found that metformins and statins are associated with a reduced risk of biochemical recurrence. But what this study is specifically doing is looking at men late in the disease course and with advanced disease. So it wants to I'm looking specifically at whether using metformin and statin after biochemical recurrence, so after you've had a recurrence of prostate cancer, can reduce your risk of all-cause and prostate cancer-specific mortality. And then also whether when you're diagnosed specifically with metastatic cancer, can that reduce your risk of all-cause and prostate cancer-specific mortality. So I don't think there's any studies looking at both recurrence use, and then there's limited and inconsistent evidence regarding metformins and statins after diagnosis with metastatic disease. So this particular study, partly because what the grant mechanism was interested in, is looking really at men with advanced disease or men that have had a recurrence already. So here's the aims of this project. And so it's to determine whether metformin and statin use is associated with a lower risk of death among men diagnosed with metastatic or non-metastatic prostate cancer. And so I hypothesize that metformin use after diagnosis with metastatic prostate cancer will be associated with a lower risk of all-cause and prostate cancer-specific death, and the same for statin use. Statin use after diagnosis will be associated with a lower risk of all-cause and prostate cancer-specific death, and then there'll be a synergistic association between metformin and statin use. So people that are on both metformins and statins will have a lower risk than people that are only on one drug. And then the second aim is similar, but looking at men who had a recurrence instead of metastatic disease men. So determine whether metformin and statin use is associated with a lower risk of death among men that had a recurrence, and then hypothesize that both metformin use and statin use will be associated with a lower risk of prostate cancer-specific death and all-cause death among metformin and statin users, and that there'll be like a synergistic association. So the data source that I'm using national VA data for this study. So this is data from the VA, that is the Pharmacy Benefits Management System. So here's where you can get all the drug information, the decision support system, the VA Clinical Cancer Registry. So this is where you can get information on their cancer treatment and their cancer outcomes, and then vital statistics data, so whether they are alive or they died. And so what's unique about this study is it's all men that are diagnosed with prostate cancer at any VA hospital between 1997 and 2009. So it's about 150,000 men. And what's unique because this is the VA's, about 30% of the men are African American. So we can look at these outcomes or these associations in high-risk men, which a lot of studies have not done to date. There's several advantages of using the VA cohort. The data is stored in a common electronic medical record for over 10 years, and there's detailed information available for key variables, including medication use and duration, PSA values over time, which is important for defining recurrence, BMI and treatment type. Race is recorded independently by the VA Clinical Cancer Registry and is available for 98% of men. And it includes both academic and non-academic medical centers across the country. So a lot of studies, you'll find single institution academic centers. So this allows us to do that. Look at both. And then another thing that's important about the VA is that it provides care regardless of insurance status. So the study can control for like socioeconomic status and access to care in ways that some other studies are not able to. So as I mentioned, the primary outcome is metformin and statin use. So I'll start by looking at a binary use and no use, and then look at cumulative duration in the time period of interest. So duration after biochemical recursion or after diagnosis with metastatic disease. Our outcomes, as I mentioned, are all-cause mortality and prostate cancer-specific mortality. And then we have access to a lot of important confounders in this data. So here are just some, and this is very preliminary data talking about the cohorts. Like I said, there's about 150,000 people. The average age is diagnosis is about 66, and both metformin use and statin use are prevalent in this cohort. So about 21% of the men are on metformin. A very, very high proportion of the men are on statins in this cohort. So almost 70% of the men are on statins, and then about 20% are on both metformins and statins. About 30% of the men are diabetic, and about 35% are obese. And even though like metastatic disease isn't super prevalent because the overall cohort size is so large, we still have about 7,000 metastatic men in the cohort. And so because it's taken a long time to transfer the grant from WashU to University of Delaware, I don't have a lot of data to show you, but here are just some very preliminary findings which look promising. So again, this is just looking among men metastatic disease, and on the first two columns are looking at the full cohort, and the two columns on the right are looking at Black men. And what we find is post-diagnostic metformin use in the full cohort is associated with a reduced risk of all-cause mortality and prostate cancer specific mortality. And again, we see the same protective inverse association for statin use, both for all-cause and prostate cancer specific mortality. These are adjusted for limited confounders. And again, this right now is only looking at by use, no use. So only did they have use post-diagnosis of metastatic disease. So importantly, like I said, 30% of this cohort is African American. So we can look at this in high-risk men who are more likely to get and die from prostate cancer, but have very few studies with significant numbers. And again, we see very consistent results. So post-diagnostic metformin use among metastatic Black men is associated with a reduced risk of all-cause and prostate cancer-specific mortality. And again, we see the same thing for statin use. And our hazard ratios are fairly strong. They range from about like 0.7 to 0.5. So these are some promising initial results. I mean, the next steps would be to look at duration, account for pre-diagnostic use, and look at the interaction. So like I said, these are very preliminary findings. So the significance of this project is that it's using population science to examine a low-cost, low-toxicity strategy to potentially prevent progression to lethal prostate cancer. It's a nationally representative sample with a significant number of African Americans, and it focuses on men with advanced cancer. And it's ultimately working towards developing effective treatments in men with high risk or metastatic prostate cancer. So maybe like metformins and statins could be used like adjuvant therapy with additional with surgery or radiation or other typical treatments. And it has the potential to improve the quality of life of men with advanced disease. So I just want to talk a little bit about my future directions, and because I'm very happy if you guys have interest in future collaboration. So feel free to reach out to me or send me an email, whether it's a prostate cancer, anything that's related. Would be great. I'm excited to start new collaborations here. So feel free to reach out if you have any ideas or have potential. So here is just an overview of this project that I talked about right now. But what this project is really focused on the late disease course. But what I'm really interested in is what is the critical window for metformins and statins use? Do you have to? Is it more beneficial to have it throughout the life course, like before diagnosis, throughout the cancer continuum, before and after diagnosis with prostate cancer, or is it okay to just use it like after diagnosis? And what is the critical window for exposure? But what I'm really interested in is, well, the study I'm doing right now is going to, adjust for diabetes status, but I'm really interested in what happens as diabetes progresses throughout the life course, especially when people go from metformin to insulin as their diabetes progresses. Because while metformin is associated with improved outcomes, insulin, which is people use when their diabetes is more progressed, is a growth factor for prostate cancer cells. So what really happens when you switch from metformin to insulin, how that impacts your prostate cancer outcomes? So more broadly, how commonly prescribed drugs in chronic cardiovascular disease management in prostate cancer outcomes is a question I'm interested in. And what is the impact of metformins and statins in other cancers? I mean, obviously, most of my research to date has been on prostate cancer, but I'm happy to expand to other cancers if there's, potential for collaborations. In terms of the modifiable risk factors I talked about, I previously showed in the study that gaining weight from age 20 to 50 is associated with weight gain, but that study was largely limited to white men, and it was only at this like 20 to 50. But I'm really interested in the trajectory of weight gain throughout the life course. Is it that you like consistently gain weight, or you just gain a bunch of weight in midlife, and what is associated with the worst outcomes, and which is worse, and where can you intervene to improve outcomes? So like I said, a lot of we talked about a little bit earlier that PSA screening now is a shared decision making between you and your provider. So I'm interested in whether some of these modifiable risk factors, such as smoking and obesity, can be used to influence like PSA screening indicators. And even I just have the Delaware Cancer Consortium recommends that non-Hispanic African American men have a discussed prostate cancer screening with their doctor or health professional. So whether these like modifiable risk factors can be incorporated in the discussion and help make more informed decisions. And finally, just broadly, I'm interested in survivorship. So how can we reduce disparities in survivorship, whether it's like through, and how, especially for prostate cancer, because people with prostate cancer are living a long time with prostate cancer. It's a highly survivable cancer. So you're also managing other chronic diseases as a prostate cancer survival, and how this impacts your prostate cancer outcomes and how well you manage these chronic disease, and what factors contribute to guideline concordant care and can improve long-term follow-up care in men with prostate cancer. Because in one analysis I did in using the WashU cohort, almost 25% of men do not receive adequate follow-up care following radical prostatectomy. So I think this is super important, especially for a cancer like prostate cancer, where you're living so long with prostate cancer. And I just want to thank my mentors and collaborators and my funding sources. And here's my contact information. I'd be more than happy to collaborate. If you have any potential collaborations or any paper or anything, please feel free to reach out to me. And thank you so much for coming. Yes. So if I know about breast cancer or
similar research that would. It's a known risk factor.
So that's an interesting question. I don't know that off the top of my head. I do know that like if you're on metformins or statins, you have improved like less risk of prostate cancer mortality and like men that are diagnosed with like early stage non-metastatic disease, or has a lower risk of recurrence. So I mean whether that's a question of partly it's probably through the mechanisms of metformins and statins, but partly it could be the people that are on these medications are getting regular clinical care and like are probably healthier and they're managing their. But that's a very fascinating question that I haven't really know about, but that'd be fascinating to look at. Okay.
So one of the questions that I had, I'm sorry I came in late, but it was related to the mechanism and specifically as a
right.
That are hormone active. You had mentioned.
Right.
But I do wonder among classic men, they often have.
Right.
So they're the insulin
working.
so
right.
Is the activity of methylation part of that? Is it actually allowing them to production and not
extra insulin circulating? Yeah, that's an interesting. I'm guessing there's multiple pathways that like. Yeah. So that is fascinating, and so like I said, like a future direction, I'm interested in what happens like when you go from metformin to insulin. So I don't know. Are people like when they switch to insulin? Are they on? Do they stay on metformin or do they like then or do just switch to insulin? So what happens when they're yeah? So I'm interested in what happened. But yeah, I think that's a possible mechanism as well. So I think again, there's a lot of hypothesized mechanisms, and there's probably multiple pathways that are leading
But I
to.
think it'll be important.
Yeah. Right.
So type 2 diabetic.
Yeah.
Other medications. Once they become FDA advanced, so they're actually they need extra insulin severe.
Yeah.
So I would just the other piece. But we do have some about this. Experience. Okay. Like breast cancer, diabetes, morbidity, and there. I was just.
Perfect. Yeah. No, I agree sorry, that would be awesome. I'm looking for collaborations, but I agree that the insulin piece is important. So I think like I'm going to apply for like the CTR grant. One is like using the VA data to look at what happens when people go from metformin to insulin, and just like in this like observational study, what happens when they're on insulin in terms of their survival outcomes. But yeah, I agree that's very important. And this is looking at only one piece of like this study is looking only at one piece of like the cancer continuum and only one piece of like the diabetes treatment paradigm. But thank you. Yes.
So in your last study, the study of metformin,
yeah,
statin, I mean, most of the patients were on metformin.
Right.
So, I mean, wouldn't you just select out of your population only the? I'm not quite sure I understand.
Right. So I think that would be more for the people that are on statins and like not metformin, because they're looking at metformin and statins, and then we're going to look at for people on both on metformin and statins. So probably the metformin and statin piece will be like only people with because they're going to be diabetic if they're on the medication, but people could be on statins without metformin. So I think that piece of the study will probably be like not necessarily excluding the non-diabetic men. Thank you so much, everyone.